let's go back to your patient. So we have a patient with a high volume disease who was treated per chart or a stampede with upfront ADT plus 6 cycles of docetaxel, and now is progressing. There's a lot of factors to me that matter, right? So I want to know, how is it progressing revealing? Is just numbers, or is numbers and more disease in the scans? Is it now developing more visual disease, or is just, or is disease more bone disease only, right? And does the patient symptomatic or not? So
so he presented with significant bone disease. He had 6 lesions. Mm-hmm. He got 6 cycles of ADT and docetaxel. He had no soft tissue, no visceral, and his PSA is now going up. His other labs are normal, and he has 2 new bone lesions, right, and he's mildly symptomatic. He's receiving NSAIDs.
So you are almost describing the ideal candidate for that when we think about radium 223, if there's a place for it. I have to, so just a reminder on Alcinca data, right? We have, that's the best, I mean, level 1 data for we have 50% of patients who received it pre-docetaxel, roughly half pre-doce, another 50 post-docetaxel. We took symptomatic patients, however, 40% or so didn't actually get opioids, right? So 40% or so got mild to moderate, and then moderate to intense pain. And we also know from radium 223 a couple more of important data. One is, if we want to do radium, we really want to commit the patient to 5 or 6 cycles because we know they do better. Also, the fit patients that we call 0s to 1s are those who do better. And we exclude patients who had nodal involvement for more than 3 centimeter lymph node or visual disease. So when I put in the more recent data that we had that was important too is actually adding it with Zytiga, or the abiraterone, excuse me, is actually a negative safety signal there, and so we want to stay away from that. Knowing that, and knowing that both Cook 302 and the Prevail data did not actually, Prevail took 12% of patients with visual disease, Cook 302 actually took 0%. But we all know it works for patients with disease outside the bones. So saying that, I do have a bias because for a patient that is progressing with numbers only, so we have serologic progressive asymptomatic, I think it's a great opportunity for us, especially if he's African American, to offer a CPT, a simple SLT, Prevenge. Think about radium. I oftentimes offer it after the first AR-directed therapy. But if you ask me, would that be wrong to consider for a patient with some symptoms, bone-only disease, and when we expect him to be able to get 5 or 6 cycles of radium 223, I have to say it's pretty straightforward. I think it's a very reasonable thought process, right? But really, when I try to identify the best timing for radium, I also like to bring the PST3 data where we're actually doing, and I know, Neil, you are involved in that leading those efforts, where so far we have not seen a safety concerns there, and on top of that, it might be adding us a benefit. The reason why we have done a lot of combinations with AR target therapies because, as we know, radium 223 is approved based on survival, but it does not impact the PSA behavior, PSA kinetics, nor it impacts time to disease in the scans. And a lot of us get concerned because we're giving a treatment for a patient for, let's say, half a year, and we can see PSA continue to go up, and we might see more disease in the scans. So for a lot of us and a lot of physicians in the community, that creates a lot of pressure, right? And for patients too, because they don't want to see PSA going up, they don't want to see more disease in the scans. So that's my bias, and we all have our biases, but I would argue for the most part, I tend to start them on the first AR-directed therapy. And right now in the CRPC setting is going to be abiraterone or enzalutamide, and I think if CPLCLT makes sense. The reason why I brought up the question about African Americans is because we got data in the real world data where the signal for survival favoring African Americans is actually a huge difference favoring African Americans compared with Caucasians. So I work in my practice in Louisiana is actually the African American population is actually real, right? And it's more than other places in this country. And so those are the kind of factors that I take into consideration when I try to say what's the best treatment. And I have to say, sometimes there's more than one best treatment for that patient.
Right. I want to comment about the Alcinca data. There was a survival benefit. That's why it got approved for radium 223. But the arms were not just radium 223. It's radium 223 plus best supportive therapy, best standard of care. Now, the time the study was done, the choices were things like ketoconazole, MCIT, prednisone, some other oral therapy, enzalutamide, apalutamide, abiraterone. Those drugs were not approved. They weren't available. So it's very reasonable to consider, as you said, enzalutamide plus radium-223, starting them at the same time. You then have benefit in terms of PSA dropping. You're giving a second-line androgen-targeted therapy that's going to be beneficial, and there's absolutely no reason not to put those two together. You mentioned the data on abiraterone and radium-223, some problems with more radiologic events and worse survival. So reason why we tend to stay away from it, but there's absolutely no reason not to go with the enzalutamide radium-223 at that point in time. Assuming, if you wanted to sandwich in some sipuleucel T before you did both of those,
Yeah. That's great points, and so much of it is what's going on in the bone microcompartment, and in the ERA-223, everything was given concomitantly, and so what we've done in some phase 2 studies, and Niraj Agarwal has also done this too in some of his work, is we looked at layering, and we've just recently showed a large meta-analysis. We presented a poster at ASCO GU on real world, and a lot of it isn't started concomitantly. There's a layering, and layering is defined by starting the abiraterone or the enzalutamide 30 days or more before the radium. And is there something happening that's allowing for the bone flare that you may see with those drugs? And maybe there's some blast-class homeostasis that's happening so that when you hit with a drug real powerful like radium-223 with its apoptotic effects, it's better tolerated in terms of risk of fractures. But William, what are your thoughts? You've done some great work on these combinations as well.
I mean, of course, again, is summarized really well by Pedro before, but there are a few important things to point out. I think AR-targeted therapies, I think most people would agree, are the standard of care for the vast majority of these patients, Abi or Enza. And it's just the preponderance of evidence, the quality of the evidence, and really, I think for most of our patients, the tolerability of the drugs and the way in which it's working. That's what I would generally use. I think the issue, I do think there's a role for CYP-T in some of these patients, and I think the African-American data that comes from Oliver and Pedro are very, very interesting. I think there are some patients who may be very bone predominant where you might really think to start with radium. But I think most of the data really would suggest that the patient you described, Neil, is a pretty classic one. And like Alicia said earlier, I think mechanism of action is very important. This is a patient that I would go from chemo, early CRPC, and start AR-targeted therapy. I think the only point I would say about layering and combinations in the absence of really high-quality level 1 evidence is, with ERA-223 and also with PEACE-3, the most important thing that I took from those studies, the most important thing that I learned is don't forget about osteoporotic fractures. Matthew Smith and others have been, Tia Hagano have been talking about this for years, and I'm pretty good at it, but not as good as I thought I was. And, we're all focused on cancer, but what happens is this kind of adjunctive therapy, osteoporosis or osteopenia, is leading to some real morbidity in these patients, and I think we have all seen it. The patient's in remission, his PSA is 0, and he calls and he's like, I have severe pain, or he goes to the emergency room. And when you see it, it's actually quite disturbing. And so I came back from that ASCO last year where Bertrand Tombal talked about PEACE-3. Now, just as a reminder, if you're on any of these combinations, on radium plus any AR-targeted therapy, but even if you're on AR-targeted therapy alone, there's a much higher rate of osteoporotic fractures than we appreciated, up to a third. And if you're just on AR-targeted therapies, it's still like up to 10%. It's 5 to 10%. So what we started doing is making sure that our patients are getting bone density tests if they're not already on a bone-protecting agent. So I think that's the most important lesson. If you're going to do combinations, it's not to do more harm than good. But in the meantime, I do think that there are many options for the patient you described. And I think they're all reasonable and can all be argued for. But I think probably in my practice, most of my patients are getting abiraterone, more so now because it's generic, so their copays are a little bit less, and unless they have a contraindication, or enzalutamide if they haven't already received it earlier.
You make a great point about the bone health agents or the anti-resorptives. You're spot on about that. It's absolutely essential to make sure they're getting either zoledronic acid or denosumab when they're getting these combination therapies when they have significant bone disease. But I still find some of my patients I have to hold back because they have really bad dental
yeah, it's such a
hygiene.
difficult thing.
It's a challenge, right? And you
really-
want to avoid this whole OMJ
Yes,
issue.
yes.
But you're absolutely right. That has to be standardized in everybody's thought process.